Welcome, everybody. I'm very happy to have the opportunity to talk a little bit about the next generation balloon guiding catheters and also about the basic principle of flow arrest itself, and of course, a little bit of about the new straight study, which was evaluating one of these new kind of devices. So these are my disclosures. Just to begin with, I think most of you will be familiar with the basic principle of the flow arrest itself. Just to make a short recapitulation of this principle itself. So what you see here is when you have a clot stuck in a stent retriever, which is here a stained clot inside a retriever, and you start to just pull this stuck clot inside the retriever backwards through all the elongations and curves of the ICA, then in many cases it will happen that the clot, if it's not that stable, will disintegrate and parts of the clot will move during this pulling procedure towards the end of the uh, towards the end of the stent retriever, which can be seen here. And in the end, when you just retrieve it inside your guiding catheter, then parts of it might get stuck at the tip of your catheter. And if you are at that point, you do not have a patent flow arrest, for example, with a balloon, then this kind of fragment will just go upwards and produce a new occlusion. So this is maybe the clear principle of creating flow arrest. And so this is the model, and that this is also true in reality could be shown by a lot of studies which were done to compare the outcomes and the technical successes of using a balloon guider or not using a balloon guider. And what you can see in this good review of nearly all studies that are existing to that topic, you see that uh, might should it be the TICI, so the technical success is better, the first pass effect is better, the MRS, so the outcome is better, and this is also true for the different techniques that you use. So if you use aspiration, stent retriever, or a combination of both, in all of these techniques, the balloon guider is superior. The highest impact seems to be when you use just stent retriever technique. But these kind of evidence is true for the old generation balloon guiding catheters. And in the last years, there have been several new devices becoming available, which is, for example, the Walrus, the Embogard, and also the Bobby, which are different regarding their technical features, their stability, their trackability. They are now at least as good as conventional guiding catheters, but we do not have really evidence for these kind of balloon guiders. This is the only retrospective series that we have for the Walrus catheter, which could show a very high rate of successful recanalizations and also high first pass effect, although this is a retrospective analysis. So what I would like to show to you now is the evaluation of this new device, which is one of these three. So it is compatible with the large distal aspiration catheters like the Sophia 6 French, and it is very good trackable and stable. So we try to evaluate this new device in a prospective way, in a prospective multi-center single-arm study, which took place in 9 centers in Germany and Switzerland, and where 171 patients were enrolled. The primary endpoint was also a technical one, so successful reperfusion, defined as TP larger than 2B, but we had a lot of secondary endpoints We had a look at, for example, first pass effect, safety endpoints, of course, but also clinical endpoints like the MRS after 90 days. The main inclusion and exclusion criteria were quite standard. Also, just to keep the results comparable to the existing literature, so anterior circulation, large vessel occlusion, which could be treated within 8 hours of symptom onset, and not too much uh, too high aspect score, these kind of things. After 115 patients, there was an interim analysis performed, which was pre-planned, and we saw also already in this analysis a very high rate of success. So the hypothesis was already met, and that was the point where the enrollment was stopped um, at 171 patients, and this is now the analysis, the presentation of the final analysis, which is, by the way, not yet published. We have a full analysis set and a per protocol set, which is a little bit a smaller number of patients, but as these two subsets of patients do not really differ in any of the key variables, I will stick to the full analysis set in the next few slides. Baseline characteristics are quite standard, as well as all the other baseline variables, very quite heavy strokes with a median NHS of 15. And these are the times most patients have been uh, have received TPA, meaning also that the time of the procedure or the treatment was quite early. Occlusion sites, mainly M1 occlusions and M2 occlusions, and some carotid T occlusions were present in these cases. Here you can see also the time to treatment, which was in the median below 3 hours, and also the intervention itself quite fast with 40 minutes. Most patients have been treated under general anesthesia, and the main strategy for recanalization was the combined one with stent retriever and distal aspiration. Only few of the patients had to be stented intracranially as rescue therapy, and we actually had two successful reperfusions by just aspirating at the balloon only, and they did not need any further other strategy. Regarding the placement of the bobby, it was possible to place the tip of this catheter in nearly 2/3 of the patients in the distal or mid-segmental parts of the ICA, which was of course mediated by the elongation of the ICA. And coming now to the primary endpoint, which is the successful reperfusion, this was as in the interim analysis, 95%, so very, very high. And also the first pass effect here was 63%, very high. And these numbers are more or less exactly the same as in a retrospective wicked study, but now collab controlled and prospectively, so a much higher quality of the data. What we also saw is that the placement of the tip of the catheter really had an impact on the recanalization success. You see that there is a drop in the rate of first pass effect from the at least mid-segmental part to the just ICA bulb of about 20%, and also this is of course related to the anatomy of the ICA. there were no symptomatic intracranial hemorrhages within 24 hours. So regarding the safety, there were no problems that we could identify. We saw about nearly 6% of embolizations in new territories, which is actually the event we wanted to prevent with using the balloon guider. And nearly in all cases, there was a hyperdense clot sign if we had these events, meaning that this might be a less stable clot. Functional outcome also very good, which is more or less clear with these in and exclusion criteria and this high rates of success rates, and also quite low mortality rate. So these are the data from the study itself. What I wanted to present now or to end up with is a practical example where you see the capabilities of these new kind of balloon guiders. This is one of the cases that all of you know quite hard. Aortic arch, where it is difficult to get your guiding catheter placed in an optimal position, and you see that it's hard to just advance the SIM catheter further because you always have this force downwards. And what you can do now with these catheters is that the quite flexible tip can be advanced in the proximal ICC, and if you at this point start to just inflate a little bit or partially inflate the balloon, then you create kind of a kite effect, which stabilizes your whole system. And then it's possible to further advance the inner catheter, and then you can just deflate the balloon again and advance the balloon guider more upwards until you arrive in the ICA. And then if you reach this position, you can just see how the occlusion side is. And then you see you have another kinking here of the ICA. And after having deployed your stent retriever and the distal aspiration catheter, when you now pull a little bit at your system, then you see that these catheters will go upwards, will straighten up the vessel, and then you can achieve a position which is directly at the skull base. This is the position you want to reach because at this point the ICA is fixated uh, in the Petrus canal. Then you can inflate your balloon, and if you aspirate, you will not create a vessel collapse. So this is the optimal position that you can reach, and after one maneuver, then you have this successful result. So these kind of things are possible with these new generation devices. So, in my personal opinion, I think there are no really disadvantages of these if you compare them to conventional guiding catheters, except maybe the price. But regarding their properties, their physical properties, it is really there. You have a lot of possibilities that you can use additionally to a conventional guiding catheter. Even if you think about if you have a complication inside the brain, a bleeding or something, and you can just block the flow, then you have also a safety benefit. So I think there are a lot of reasons to use these kind of catheters. So in conclusion, well, this is what we saw in the study, in the prospective evaluation, high rate of um, uh, actually success. No really safety concerns. And so I think we can provide with this study new evidence for these new generation guiding catheters. And interestingly, we saw the high impact on the optimal balloon guiding placement, also in our data, and also the impact of the clot characteristics on the success rate. So there were several interesting side information that we could draw out of this study. So thank you very much. I hope I could give you some new information and wish you a lot of fun for the further Congress in Zagreb. Best regards.